Welcome to this first Health and Wellbeing Board meeting of this new term. Today, Thursday, 10th of July, 2025. Just a few note of caution. This is going to be audio recorded as well as video recorded, so make sure you are not exhibiting anything in front of your desk so that it doesn't fall on the camera. The way we start is usually we go around and introduce yourself, just two sentences, who you are, what are you doing, and while you speak, please press the button of the microphone in front of you so that we all can hear it. Starting with me, I'm Paul Ejit-Shelvan. I chair this meeting, and I'm a councillor for Cramlington South East. Thank you.
Good morning, everyone. Graham Size, I'm a GP in Alnwick, and I'm a clinical lead with North East North Cumbria ICB.
Good morning, everyone. It's Jill O'Neill, Executive Director, Public Health, Stronger Communities and Inequalities of the Council, and I'm also the Statutory Director of Public Health.
Good morning. I'm Councillor Eve Chicken, a Cabinet Member for Adult Social Care and Health.
Morning everybody, Audrey Kingham. I'm Exec Director for Children's Services here in Northumberland and the Statutory Director for Children's Services.
Good morning, my name is Rachel Mitchison. I'm Director of Delivery for Northumberland and North Tyneside for the Integrated Care Board ICB.
Good morning, Abby Conway. I'm the Chief Exec of Citizens Advice, representing the voluntary sector infrastructure contract Thriving Together.
Hello, I'm Rachel Rispin, Service Manager in the Growing Healthy 0 to 19 Service Northumberland, here representing them.
Hi, I'm Dewi Nugent from Health Watch Northumberland.
Hello, I'm Sharon Williams from Community Pharmacy North of Tyne.
Good morning, I'm Karen Martin. I'm Service Director for Adult Social Care Assessment and Safeguarding, and I'm deputising for Neil Bradley, the Exec Director. Thank you.
Good morning, I'm Alan Smith. I'm the County Councillor for Cramlington, Eastfield, Parkside.
Good morning, my name's Carl Green. I'm a newly elected County Councillor for Seatonwood Spittal, which is in Ashington and Newbegin.
Morning, I'm John Caseley from Northumbria Police and specifically Northumberland Area Command.
Morning, Lindsay McVeigh. I'm Interim Chief Fire Officer.
Glenn Sanderson, Leader of the County Council.
I'm Michelle Bolelli. I am the Service Manager of Northumberland SIPS, here representing Chloe Mann, Director of CNDW.
Hi, I'm Donna Latham. I'm one of the heads of service in adult social care. I'm here representing the dementia strategy.
Good morning, I'm Carol Paz, Senior Quality Improvement and Assurance Manager in Adult Social Care, and I'm doing the presentation on dementia this morning.
Andrea Todd, Democratic Services.
So we now formally begin the meeting. The first item is membership. So can you all please note the membership that is at the front page of your agenda. And just a remark that there are some new members. I have given them a copy of the terms of reference, so which explains the purpose of this meeting. So please go over it. Basically, what it does is that what we are here for is basically to encourage all health and care organizations to work together in an integrated manner. That's all it is. And also, Council has got these three aims, one of which is tackling inequalities, and we also have that in mind because it's quite relevant to this board. So please feel free to ask questions, make suggestions after presentations. It's more or less a discussion chamber. Every question, every recommendation, every suggestion is valued. Okay, thank you. And remark two, the final remark, is that we have a representative from Northumberland Health Watch. The chair used to attend this meeting, Peter Stanfield, and he is stepping down. So in his place, we have Derry Nugent, and I formally thank Peter Stanfield for all his contributions in the past meetings. And I welcome Derry to this meeting again. And also, we will be sending a formal thank you letter to Peter. Now, the second item, apologies for absence.
Chair, we have apologies from Neil Bradley, Ross Wingham and Chloe Mann.
Noted. Minutes of the previous meeting that was held in 10th April 2025, in the previous era, before the election. So shall we all agree the minutes of that meeting? Thank you. Fourth item, disclosure of members' interests. Anyone has any interest in the items we are going to discuss? None, I see. The fifth item is the election of vice chair. So Graham on my left is the current vice chair, and the role of the vice chair is to be renewed at the beginning of each term. And I propose Graham continues to play the role for one and only reason. You know, one of the statutory functions I just mentioned of this board is to bring together all the organizations and to make sure they work in an integrated manner. I think it would be nice to have a vice chair from NHS and especially a clinician. So therefore, I propose that Graham continues. Is that okay? Okay, thank you very much. Graham, congratulations. Thank you for all your contributions in the past.
Can I say something, Chair?
Yeah, please do.
Thank you. We had a discussion about election of a vice chair. I would be honoured to continue to be the vice chair at the present, in the knowledge that the ICB is undergoing changes at present, so my role moving forward may change, but for the time being, I'd be happy to continue and keep working on the inequalities agenda and bringing everybody together, and it fits with my role as chair of our local system board as well. And there's lots of things about integrated neighbourhood health and teams and inequalities in that. So
thank you very much.
But I didn't want to nominate myself, and obviously we have to go through a due process. So if anybody was interested in knowing about the role of the vice chair for the future, I'd welcome anybody to approach me. But I think having somebody with clinical knowledge, a clinician, really helps. But that doesn't have to be a doctor. I just need to state that as well. There are many clinicians who are not doctors that work in healthcare too.
Yeah, that's what I said. It will be helpful. So
thank you.
Sure. Sure. You've been a fantastic vice chair for me in the last 3 years, so I'm quite happy to work with you, Graham. Now, move on to the sixth item, Better Care Fund? Yeah, Better Care Fund, a oral narrative, not a presentation, from Rachel Mitchison. Please.
Thanks very much. Just very briefly, for those that don't know what the Better Care Fund is, because I appreciate we've got some new members, the Better Care Fund is, in a sense, a pooled budget that comes across the NHS and the local authority so that we work well together to provide good health and care services. Predominantly, services in there are linked to how we support people in the community, how we help them leave hospital in a timely way, support them back home, so reablement, equipment, therapy services, that sort of thing. So we work very collaboratively in Northumberland. We've done it for a number of years, and then every year we submit a plan to just show how we're doing it. So this year's plan was submitted on the 31st of March, and members that were here at that time will have received a copy of that plan. We circulated it round for comments, and thank you for those that did provide some comments. They were incorporated into the plan prior to its submission on the 31st of March. It then goes to NHS England as a regional panel and gets sort of moderated across all the other plans, because every local authority will submit the plan along with NHS colleagues. Our plan came back to us. We'd written a very concise plan, which we had thought was the ask. Our plan was 6 pages. We were told that some plans were 33 pages, and we were asked for some additional information. And maybe we had assumed a bit of local knowledge with some of our service descriptors. So we provided that narrative and that extra information, and we resubmitted the plan on the 29th of April. And I'm pleased to report that on the 3rd of June, we were approved. Our plan was approved by that panel, and so that is what we are now working towards. There was one slight question around a data, a change in how they're recording the data for delayed discharges. Now, our performance is good, and our overall average for all patients is half the national average, so we're not worried about the actual performance, but they've changed an indicator, and that's having an impact on how it's looking. So we're just waiting with the trust to kind of work out what they've changed and how we can work on that. But overall, the plan was approved, so it was just to update the board about that. And if new members want to see that plan, very happy to share it.
So it's always gets approved late, isn't it, Rachel? So is that causing a problem? Was there?
Well, it does usually come out late, so it doesn't allow us a huge amount of time. But I think this year, did we have an event in February? A closed session, that's right. So we couldn't bring it to February, which is why we did it virtually. So I think that's what we did this year. But generally speaking, we don't get a lot of time to, by the time we get it, to reply back. And then fit in with the timetable of the board can be quite a challenge.
Okay, thank you. Are there any questions for Rachel? No? Okay, thank you very much. So we will then move on to the beef of the meeting. That would be introduced. That's a Northumberland dementia strategy that will be introduced by Councillor Eve Chicken, Cabinet Member for Adult Services.
Thank you, Chair. In a moment, I'll hand over to Carol, who will actually deliver this strategy for you. I trust you've all had time to read through your papers. This strategy is not just necessary, it's actually really exciting to see. This has been constructed with the service user in mind. So they've taken on board advice and the lived experiences of the service user, that is those with dementia and those who care for them, because it is such an important part that we look after everybody within that process. So this isn't a flimsy strategy that's going to change every couple of years. Nobody knows where they're at, nobody knows what they're doing, and you're having to re-implement something brand new. Everybody starts again. This is a 10-year robust strategy. Like I say, this is really exciting to see. Nobody is not touched by dementia. We all know somebody, we all either suffer from it, have a parent, a grandparent, or even just an elderly neighbour. And unfortunately, it isn't just the elderly that suffer from dementia, there is premature dementia as well. This plan has taken a lot of time, a lot of effort and a lot of expertise to put together, and I'm really excited to see this strategy rolled out across the local authority and further. So now I'll hand over to Carol, who will give you the integral detail. Thank you.
Thank you. Just to say thank you all for asking myself and Carol here today. Firstly, we want to say how fortunate myself and Carol feel to have been given the lead for pulling together the dementia strategy. And even though it's just the two of us up here presenting, actually there's been a wealth of people behind, that have actually put so much effort into this. Public health, CNTW, the voluntary sector, ICB, been absolutely loads of people involved in this. We're obviously very, very passionate about it, and I think, as you said yourself, Eve, we're all touched by dementia. Myself and Carol both have lived experience. We've both got parents that are on different journeys within their dementia. So we've got an absolute vested interest for this for this dementia strategy. And one of the things is what we're really, really clear about is that it's not a strategy that's just going to sit on the side. The main thing, the really important thing, is the dynamic implementation plan, how we move this forward and embed this across, because it's really important. We're really invested in the people of Northumberland and want to make a difference. So I'm going to give over to Carol to do the presentation.
Thank you, Donna. So we're going to talk about some dementia statistics in Northumberland. We're going to talk about what's already in existence. What we didn't want to say is that we're starting from ground zero in Northumberland. There's already been some brilliant work that's happened, and we wanted to acknowledge that and build on what's already happened. We're going to talk about how we develop the strategy, who's involved, and importantly, what people told us. We said from the outset we wanted this to be guided by people living with dementia and their carers. So we've done a lot of work with Dementia Voices Group, with the Alzheimer's Society, and with some of our post-diagnosis memory service clinics to talk through what some of the challenges are for people who live in Northumberland living with dementia and carers. And then I'm going to go through a little bit about what the strategy includes and some next steps. So the whole strategy has been formed by a public health chapter on dementia, and a lot of our statistics have come from there. So towards the end of October 2023, we knew that a total of 5,399 people aged over 65 or older were living with dementia in Northumberland, but we know that that is going to increase up to nearly 9,000 by 2040. So it's something that across all sectors we know that it's something that we need to be aware of and that we need to plan for. It's estimated, however, that fewer than 2/3 of people with dementia in Northumberland have a recorded diagnosis. This is similar to the England estimated dementia diagnosis of 64.5%, but it is lower than the North East value. In Northumberland, we know that Alzheimer's disease and other dementias are major causes of death and disability. There are underlying causes of just over 5% of all deaths in Northumberland. We also know that the estimated annual costs of dementia care for Northumberland are expected to increase from 216 million in 2020 to 359 million in 2030. So it's something that impacts upon all of us. I mentioned some really positive existing foundations in Northumberland. So for a number of years now, we have the Blue Book of Dementia Support and Services, which is available via the Healthwatch website, which is a fantastic directory of all the services that people in Northumberland can access, both for people living with dementia and their carers. We have Frontline Northumberland, which is an online app that can refer people into services based on locality or based on area of interest and support needs. I mentioned the Joint Strategic Needs and Asset Assessment Dementia Strategy chapter, which gave us lots of information and really helped inform our strategy development. A key thing for Northumberland is our post-diagnosis service, and I know from experience in other areas that don't have a post-diagnosis service the impact that this service has in Northumberland. It's a multi-agency approach to improve the post-diagnosis experience. So once someone with who has a diagnosis, they then are provided access to the Alzheimer's Society, to Carers Northumberland, to memory groups. That can be one-on-one support or group work. It's really important at that diagnosis stage that people have that opportunity to talk through what that means to them and gain an understanding about what their dementia journey might look like. In other areas, you're given the diagnosis and told to come back in 6 months. So I think it's something that we really wanted to shine that we have that in Northumberland, and that we want to continue and really strengthen that moving forward as well. We also have the Acute Admiral Nurse Service operating within the Healthcare Trust. We also have really strong links with Newcastle University, who've done lots of research around dementia, and it's something that as partners that we want to engage with and continue with. An example is their Equidem project, which looks at inequalities in dementia, and the Stride project, which is strengthening responses to dementia in England. So a number of partners and people living with dementia in Northumberland took part in some focus groups to talk about what it was like to live with dementia in the rural areas of Northumberland, and then they compared that with what it's like in central Newcastle, and we're really trying to understand the differences in support and services. There's some really, really good pieces of work that's already ongoing, and we really want to strengthen those and continue to move forward. We mentioned that it's been a long journey, and we don't apologise for that, really. I think what it's meant is that the final product that we have in the strategy it is really robust and it's informed. So for a number of years now, there's an older person's pathway meeting that is held led by CNTW, and a number of partner organisations in that group felt that we needed a bit more of a coordinated approach for dementia. So a first workshop was held back in 2023, and then it was agreed Dr Jim Brown from Public Health went and produced their comprehensive JSNAA chapter. And then myself and Donna back last year were asked to lead and to help write the strategy, but from the start we said we can't do this alone, so we absolutely need to work with our partners. So we established the Northumberland Dementia Steering Group in July 2024. And it was that steering group that were pivotal in helping us co-produce the strategy and work alongside all of our stakeholders, including people living with dementia and carers. I talked about our steering group, but you can see there a number of the partners who are involved in the steering group. And Donna and I often say it's actually a pleasure to go along to the steering group because it really is interactive. Everybody's involved, everyone brings ideas to the table, and it's a real pleasure. Everyone goes away, does the work that we've asked them to do, and then they come back. So it's a really positive steering group that want to continue, and particularly in terms of that implementation phase as well. Of course, we bring people in if there's areas of work that we need to focus on, but this is the long-standing membership for that steering group. We talked about what people told us. So when we talked to adults living with dementia, what came out from the consultation was that sometimes people didn't know a lot about dementia before their own diagnosis, and so they weren't quite sure what to expect once they've been given that diagnosis. That sometimes the information was confusing. The diagnosis itself can sometimes take quite a long period of time. Sometimes some of the symptoms of dementia can be mistaken for other issues such as depression. People told us as well that often people think old age when it comes to dementia, but we know that we have people in Northumberland who are in their 40s and 50s with young families, and their dementia journey is very different for people who might acquire it in older age as well, so it's really important to recognise that and respond to that. They really wanted agencies to communicate better. I found this one really sad, is that some people feel shame about a dementia diagnosis, and I know we mentioned my own dad has Alzheimer's and he won't tell anyone he has Alzheimer's. He doesn't want to admit that he has Alzheimer's, and I think there is still some stigma and shame, which is something that we want to work through as a steering group. There was some really positive feedback though, that the Blue Book was really helpful. The post-diagnostic groups and home visits have provided lots of information and support. But then they talked to people about the real impact upon them and their lives. Someone mentioned they had to give up the dog. They couldn't walk the dog. There was a lack of transport in rural areas, making things harder to access sometimes services. And it was really hard to talk about the future sometimes as well, which is really understandable. So we really took into account what people told us once we were developing the strategy. So what we want to do together as a multi-agency steering group is to reduce the risk of people developing dementia and to enable and support people living with dementia to live life to their full potential. Having that diagnosis shouldn't stop, or hopefully won't stop, people from going on and leading fulfilling lives for a number of years. So we really wanted to focus on prevention, reducing people's risk of dementia by providing specific information and advice and guidance to support them to live healthier lives and manage pre-existing conditions that might increase risk of dementia, informing people so they know where to get access accurate and timely information and advice, and supporting people improving outcomes and experiences for people with dementia, and really importantly their unpaid carers and families. We decided as a steering group that a lot of the information that we were getting through and a lot of the work that we wanted to focus on fit nicely in with the NHS England Transformation Framework, which is a well pathway for dementia. And there's 5 areas that we want to focus on. That's preventing well, diagnosing well, supporting well, living well, and really importantly, dying well as well. So we've based all of our strategy on looking at those 5 areas. In terms of the preventing well, we want to raise awareness of positive preventative action, making sure we collaborate with partners across Northumberland to ensure that information, advice and guidance about dementia prevention and delay is delivered in a way that is timely and meaningful. But as well, some of our dementia carers and people living with dementia said it's really important that we do this in a non-judgmental way. Sometimes people think, well, it's not my fault that I've gone on to develop dementia, and it's really important that we're really sensitive in the messages that we portray. We want to integrate dementia risk into existing public health initiatives, so some of those risk factors, things like alcohol use, obesity, smoking, high blood pressure, high cholesterol, all of those are risk factors for dementia, so it's in making sure that we integrate dementia risk into those existing public health initiatives. And I mentioned earlier the importance of research participation and academic collaboration, finding out what's going on and being a leader in that area, really working with those organisations like Alzheimer's UK, Alzheimer's Research UK, our universities. It's important that because Northumberland is so rural and it's so large and we have very different challenges, I think it's really important that we feed into those areas of research. We've dealt some really good links with individuals within those areas. In terms of diagnosing well objectives, we really want to promote early diagnosis, so raising awareness about some of the signs and symptoms so that people are aware. It might be helpful for you to go to your GP to promote that early diagnosis. We want to continue to develop our dementia care pathway. I mentioned we've got that post-diagnosis pathway, but we really want to strengthen that and continue to make sure that it improves the outcomes for people on that pathway. Raising awareness of dementia symptoms. It's not just a memory loss, it could be behavioural changes, hearing loss. There's lots of other symptoms associated with dementia. We want to raise awareness about those. And also develop a review pathway for mild cognitive impairment. We really understand the links between MCI and dementia, and we want to review a pathway for those who have been diagnosed with an MCI. In terms of support and well, we really want to engage with people with dementia and their carers. We've done that as part of the strategy, but that's not going to be the only time that we do that. We want to continue to do that throughout the lifetime of the strategy. And the Dementia Voices groups with the Alzheimer's Society are really keen to be involved in support us in terms of any implementation. We've talked about improving information and advice and making sure that it's consistent. Implement crisis prevention approaches. So part of that is thinking about reducing the number of emergency admissions related to dementia by addressing barriers such as transportation, carer stress. Nobody wants a phone call at 9 o'clock on a Friday night to say that somebody's no longer able to support someone, so it's really important that we look at that. And also service demand planning. I said right at the beginning, we know that the prevalence is going to increase, so how as partner organisations are we going to be able to respond to that? We also want to look at effective discharge pathways, so that is from hospital into community, from or community into care home, considering emotional impact on the individual and their families. I've mentioned about younger people with dementia and about the unique challenges that they may have in terms of work, employment, family, how can we support individuals with young onset and other less common forms of dementia. A good example of that is so some of a lot of the diagnosis for Northumberland happens at the memory service, but for less common forms of dementia that might happen in the RVI and young onset. So we've linked in with the clinics who do the diagnosis there and made sure that those individuals who get a diagnosis in Newcastle who are Northumberland residents still can benefit from the post-diagnosis support that's available in Northumberland. So it's making sure those links are there. Considering the impact of past experiences, including trauma, on how dementia services are delivered, and this was really impactful by some of our carers who attend the steering group, mentioned that they really felt that trauma, in particular things like bereavement, they really can then see significant decline in their loved ones' dementia. So they really wanted us to think about how trauma impacts upon the progression of dementia. So it's something as a steering group we committed to. and also enhancing support for carers of adults living with dementia. It's sometimes and often 24/7, and the impact of not being able to leave that person who you're caring for, and how we can support those carers through that tricky time. We're looking at creating, looking at dementia-friendly communities, and seeing what's available already in Northumberland and how we can build on those. And another really interesting area that some of the carers and people living with dementia told us is sometimes it's not about accessing dementia clinics. Actually, it's accessing other clinics or going for routine health appointments, which is really tricky when someone has dementia. So thinking about dementia health inequalities in wider health policy and decision making. So considering how many, potentially you might need 2 carers to come along with you at appointments, so that one carer can park the car while the other carer can get the person living with dementia to the appointment. So real practical things that some of our carers and people with living dementia have told us. We want to explore some innovative care models, enabling people to live as long as possible, considering options, what's out there in terms of best practice. I met with the dementia lead for NHS England, North East Yorkshire and Humber, and she said the work that we're doing in Northumberland is really great. And the other area that's really progressive is Humberside. So I met with the dementia lead for Humberside just to share practice and some of the work that they're doing around some innovative care models. Acknowledge the progressive nature of dementia, managing expectations, but also sometimes offering hope, emphasising quality of life at all times. And also exploring pharmacological approaches for dementia. Things like music therapy, reminiscence therapy, effective communication strategies. In the Dementia Steering Group, the Alzheimer's Society brought along some virtual reality headsets where you can, which are being used for people in some of our residential care homes in Northumberland, where it can simulate things like balloon rides or going swimming with dolphins, or it's really calming for adults living with dementia sometimes to experience that. So it's a really interesting approach as well. The final one is the Dying Well objective. So that's really thinking about proactive end-of-life planning, looking at advanced decisions, how we can engage with carers, family members, and provide real supportive environments. And a really good example of this is one of our dementia carers whose friend lives in a care home in Northumberland, said that she was asked as the carer to work for a few weeks with her friend to talk about what her preferences would be at end of life, and she was given some resources to do that. Her friend was quite outdoorsy and she said at her end of life, and she managed to identify that she would want the window open and the curtains open at that time. So I thought that was a really lovely way for the carer to work alongside her friend to make sure that end of life was as dignified as possible. So we've talked about that with some of our care homes, and I went along to some provider forums to talk to some of our residential care homes about some of the options and just sharing those resources and good practice. So next steps, we're letting everybody know that we've had it. I mentioned I've been to we've got our strategy in place now. We've been to some of our provider forums, not just for residential care homes and nursing homes, but of our day service and things. We're letting people know that this is here. Continuing to research best practice. Donna mentioned, or the real important thing is we've got a implementation plan which is really dynamic. We're really trying to focus on what do we need to do first, what do as partners, what impact can we make to start with. And early focus areas include coordinating our approach to support adults living with dementia in prison. So we identified, for example, that social care staff go into the prison, Alzheimer's Society go into prison, AIDS UK all go into prison to support adults living with dementia. So how can we coordinate that better in terms of the service for people living with dementia in prisons? But also collectively work together to improve support for adults living with young onset dementia. So there's work ongoing at the moment to look to really try to understand what the prevalence rates are for young onset dementia in Northumberland, We've reviewed our adult social care clients who have young onset dementia, what care packages are in place. There's a new support group being put in place called Dougie's Drop-In in Cramlington, which is being set up by a man whose wife has young onset dementia for some peer support. So some really early work going on around that, but it will continue. We've got some links there in the presentation that will be circulated, and I'm happy to answer any questions. Thank you.
Thank you very much, both of you, for an excellent presentation. Are there questions? Yes, please, Derry.
Yes, thank you both for that. I think the first thing I would say from the Health Watch perspective is thank you for a very authentic response to the concerns that people touched by dementia in Northumberland expressed to us. And I think going back to our engagement around the long-term plan all those years ago, this is exactly what we were hearing, all of the things that you've mentioned there. And I think especially the movement on the post-diagnostic support, which was the big issue that came out of that engagement, and seeing it so front and centre and so seen as being ahead of the game is really, really important. I think one of the things I would say is from some recent work that we've done through our enter and view visits to some care homes in Northumberland, I would say that is where I think the strategy is going to be very useful, and if it can help people who have got to that stage of their dementia journey. Because I think one of the things that we found talking to people, to residents and to relatives, is that sometimes services become a bit looser around them, and they don't always get the support that they need. And I think especially around some of the community medical services, so things like audiology, some dentistry, podiatry, some of those things just don't necessarily happen quite as easily as they perhaps should. I think some of the other things that go on, the care homes are getting much better now at making sure people keep engaged, but I just think some of those things are really important to know, that dementia goes on and in a different setting, but the support needs are still there. And I think as you talked about the dementia health inequalities, and I would say that would be a really big place to look.
Thanks, Derry, and I totally agree with you, because one of the things, my mum's in a care home and she's got dementia, and I think I've been really clear when we've been meeting as a group is that you still, just because you're in a care home doesn't mean your life is over. You've actually still got to live well, and some of the homes are absolutely brilliant at actually engaging with people with dementia, and actually carrying on doing activities, taking them out of the environment. It's not the end of the story. So yeah, so I think it's a really important part.
Thank you. Fascinating and really comprehensive in what you've covered. Just from a practical point of view in my life as a GP, people who move from this place of a mild cognitive impairment who present with somebody who's concerned about them, often it's a real dilemma for both the family and the patient and the practitioner as to whether it's time to pursue a diagnosis or not. And there's definitely an element of society and expectation that just wants to ignore it if possible, because it might not be going to be dementia. And trying to have that open discussion that this might be dementia, it's almost like a cancer word. We will not mention the word dementia in the consultation, because actually that would make it much worse and more worrying if we do that. And therefore move into that place where you can talk about it and use the word dementia, I think is really important. But there's this kind of unwritten thing between practitioner and families that you might not want to say that word. And the more we can do to make dementia a word that we can all use openly, the better. So that's where a lot of what you're doing is really important. There's definitely a huge element of loneliness for people who might think they have dementia because they keep it to themselves and don't speak about it. There's a loneliness in spouses about, I'm worried my spouse has dementia, and shall I say something or not? So that whole thing again about how do you just accept that that might be a possibility in your family environment is really difficult. But then there's this thing about, they go through all of this emotional adaptation about the diagnosis, if that's what it is. And then they often come back to primary care and say, well, I've been through my diagnosis and they've done all of these things and now they've discharged me. And they don't understand why, if you've got diabetes, you never get discharged. You always have an appointment with a nurse. It's always a medical problem, whereas dementia, once it's diagnosed, becomes a social diagnosis and not necessarily a medical diagnosis, because there isn't anything to be done. But for the families, that feels like they're being downgraded. It doesn't have parity. You're just discharged. And that's where the post-diagnosis support is absolutely essential, because if the families feel they're now welcomed to a community of people who understand and know, and the meetings where you can go and meet other people and talk and understand, but they still have this, so they have a loss because of their diagnosis, because it's a bereavement and a grief, and then they have a loss because actually they've been discharged by the service who they've been worrying about going to see and getting the diagnosis. So it's fraught with difficulty. So anything we can do that does that is really important. Thank you.
I think as well that you did touch on it to some extent, but it's important to realise the impact of the dementia diagnosis on the family and the carers. And to my mind, a lot of what we see in the media, it's presented, it's always smiley faces. Sit down, hold my hand, have a cup of tea. Some families are living through hell on earth because of the behaviour, the lack of support, the isolation, and you did touch on that before, the social management of it. And it's not all just about sitting down offering reassurance. Some of the behaviours are absolutely unbearable to live with. And we condemn, in some cases, elderly families and relatives or wives or husbands to a life of deal with that 24 hours a day. Their health is not in the best condition at the best times. And you know, some deal with this and thinking, we ignore that sometimes. Maybe as the Alzheimer's Society, as you mentioned there, might address it. But the impact of carer stress cannot be underestimated.
Happy to respond. I think one of the things is Carol's actually also the carer's lead, and we've actually we've done a carer strategy as well. And I do understand what you're saying, because obviously, you know, I've got a lived experience. You know, my mum lived at home with my dad, was very agitated, very aggressive during the stage of dementia, had no insight at all into her dementia at all. And my dad, you know, he was a man of in his 80s, my mum had always looked after him. He couldn't really understand what was going on at all. And they lived down in London, were so far away. So I absolutely get the level of carer stress and actually understanding and family understanding. And I think, especially what you were saying about how it's forgotten about because you progress and that's it and it's taken away. I think one of the things I'd want to say to you is that from an adult social care perspective, you know, we work really closely with carers, you know, with the clients that are open to ourselves, yeah. We've done a lot of awareness training around carers, with Carers Northumberland, to make sure that our frontline staff are actually supporting, are actually looking at what services can be provided for that person, actually being that listening ear as well, because that does help, but actually the practical support as well. One of the things for me is around sort of, you know, I'm very fortunate, I'm a social worker, I know the system, but actually it's as a lay person, to navigate the system can be really, really difficult. You know, I'm being very open. My mum had to go into care. It's the last thing I wanted my mum to have to go into a care home. And I really struggled, even though I know the steps that you have to do. But actually, to do that for your loved one is really difficult. But I have to say it was probably the best decision, because actually she's safe, she's got stability, they're a brilliant home, they look after her, they do a great job. And actually, I've got less stress because of that. But I absolutely acknowledge what you're saying around how we need to make sure we're supporting carers, which I think we absolutely try our best in adult social care to do that, definitely.
Thanks. Brilliant presentation. You really brought the strategy to life, and I welcome that. And as Eve said, I think we're all touched by dementia in some way, shape or form. My first job was at the Alzheimer's Society for 2 years, straight after university. Humbling experience, and I completely understand when I saw that conflicting relief and guilt of carers as clients would come into Alzheimer's Society for the day centre that I worked in, but also know what added benefit that provided in relation to mental stimulation, physical activity. So it's great to see this strategy have that full pathway. People don't realise that we can reduce the risk factors associated with dementia through a lot of the work around, as you say, smoking, alcohol, physical activity, but we can also highlight without doubt that social isolation can trigger dementia as well as dementia triggering social isolation. The two things are part of the circuit. So really welcome that push around prevention and that wider awareness, because it isn't there, and that would help also with the stigma piece. And I think my second point, because we are in an ageing population in Northumberland as well, we've talked a lot this morning about the services and delivery of services, but under that living well element, we talk about the dementia-friendly approach in the neighbourhoods, and I'm just thinking about the wider group that we've got in the board. And John, I don't want to put you on the spot, but kind of putting you on the spot. I'm just thinking about, obviously, we want people to live independently in their communities as long as possible, don't they? But how do we ensure those communities are safe places to go into the high street? So I'm just thinking from a policing perspective, what's the awareness levels of managing an individual, a resident with dementia? What kind of training or awareness do police colleagues have or fire colleagues have to make sure we really are across the board, not just health and social care aware, but we're wider aware?
Yeah, I can respond to that. Thanks very much. I don't want to put you on the spot, but I'm going to anyway. I'm used to that now. Yeah, so certainly our neighbour teams and many of our police officers have had dementia awareness training, so they know. And we extend that to our volunteers as well, so our special constabulary, even the cadets get an element of training, so they're aware of what a family's going through when they're dealing with it, which we invariably do. We do get involved in a lot of incidents that involve people with dementia, and so it's really important that they have got that awareness and they're dealing with the right sort of compassion and empathy for the family. So, in a word, yes, you know, it is something that we do quite regularly, just as we get new recruits through, so that they understand what they could be facing, and certainly what a family is dealing with as well.
Just to come in, yeah, thanks. It would be very easy for us all to just say, yes, we agree. And we started to talk about it a bit, but which bits do you see are the biggest challenge to achieve in what you're setting out? And is there any ask of the partners in the room to help you achieve that? So what do you need from us to get the best out of your strategy?
I think it's keeping the momentum going. I think we have developed so much momentum over the last 12 to 18 months, and what I want to see is that continuing and just making sure, as Donna mentioned earlier, it isn't just a strategy just sits there. It's something that we are actively working towards, and I think that I think it's really important that we do get some early initiatives underway so we can demonstrate some impact. I think is really important, but also not shying away from those longer term challenges, that the prevention agenda as well, and really getting some of those public health messages out. So I'm not sure I've answered your question. I've kind of gone round the houses a bit, but I think for me it's about keeping the momentum going, and I know the partners are really committed around the table. But I think we're being really mindful as well that there's, although as a local authority we led in terms of writing the strategy and pulling the steering to it, it's absolutely a whole system approach as well, and no one organisation takes precedence over another really. I think that's a really important thing as well. We're all in it together because we know it's not going to go away and it is going to get bigger, so we have to work together to make sure that that we address what we've put out in the strategy really.
Actually, so I think going back to Graham's point, you know, I was 25 years ago, I was diagnosed as a diabetic. Immediately, the pathway was very clear, but it is shocking to see that dementia is not following the same thing. So it's nice to have a strategy that addresses that gaps that are existing now. The second remark is that you said in your presentation you simply replicated the NHS England strategy to Northumberland one. So I take it there is no Northumberland specific features that require some kind of adaptation or anything. Is it okay? Or will it come in, like, for example, as Jill said, the aging population, the rurality of our county, all these things will play a role in the implementation strategy. So I just want some clarity on that.
Yeah, so we replicated the 5 headlines of the NHS England pathway, but all of the individual objectives underneath are very much Northumberland, based on our the statistics, the prevalence, and what people have told us. So it's very much a Northumberland strategy, I think, and things like focusing on the rurality, the ageing population. But also I think what's really important is the community focus that we have in Northumberland. What came out of some of the initial findings from the Newcastle University study into Northumberland was that they saw that people living in Northumberland were much more likely to be supported by their neighbours, by their community, than they were in Newcastle. So in Newcastle it was very service-led, whereas in Northumberland, a lot of the support was around the community and neighbours popping in, making sure that someone took the medication, what like. And I think that, you know, it is starting to understand what the differences are here. But it is, you know, it's absolutely informed by what's right for Northumberland.
Yes, yeah. And the final remark, sorry, I think Graham used a nice phrase, social diagnosis. At the early stages of diagnosis, it appears it's all the people around have to notice and then to inform. In that sense, some kind of a educational thing for the entire society would be very useful. For example, when I was looking at your presentation, I came across this younger people with dementia. In my ignorance, always associated dementia with elderly people. So I never knew that younger people also can get dementia. So in that sense, I think we need to, it's in the strategy, it's very good to say, to, you know, educate people to see, you know, if you observe these symptoms, it's more likely. Again, it's a comparison, is the diabetes. So we all know what are the early symptoms of diabetics and everything. So that's very good, the educational aspect of it.
I think also it's important to remember that everybody's journey is very different, because your dementia symptoms aren't the same for everybody.
Oh, I
so
see.
some people go through, so as I said, my mum was really agitated at one stage, and then actually less so now, much more accepting. Actually, it's probably upsetting for me, but it's not upsetting for her, because actually she's quite happy in her own world, you know. But it's sad for me because it's not my mum that was my mum, if that makes sense. Whereas you'll get other people who will demonstrate sexual behaviours, fighting, you know, very, very aggressive. Other people will just completely withdraw. So I think it's really important that no one's journey is the same. It's multifaceted and it moves through different times. And that can be really stressful for families to sort of understand, because, you know, but for me, I'm hoping my mum stays as she is, but in my head, I know that I'll be really fortunate if that happens, because actually you do go like that, you know, that she may have to move homes because actually she might become aggressive or agitated again, you know, and they can't manage. So I think it's really important to know that the journey is always changing, and that can be really stressful for carers and for that person.
Dementia.
That's what we're working on right now in terms of the prevalence figures for young onset, because we don't have an accurate figure. Traditionally, it's very, very hard to define nationally and locally. So I know some of our colleagues in the memory service at CNTW are working really hard to have a look at what are the prevalence rates, and we're also linking in, as I say, with the RVI as well, to have a look at what that looks like for Northumberland. We know from our social care perspective, it's a relatively small number of clients, but the impact on those families for the duration of their life, it's huge. So it's really important that we acknowledge and support. But that's a specific piece of work that's ongoing now, is looking at those prevalence figures for Northumberland.
Okay, thank you. Work in progress.
Yeah.
Are there any questions? No. Oh, in that case, thank you very much for answering all the questions. We move on to the next item, eighth one, Health and Wellbeing Board Forward Plan. Just remind you all, any organization, police, fire, or anyone else can bring the agenda to this board, and we are happy to discuss over that one. Yeah. So if you have any item, please bring it to me or Jill and yes, yeah. You want to say something? I know I made a note. Yes. Please do bring it to me or Jill. Now Jill is going to say something.
Sorry, Chair. So this is a new term, as you said at the beginning of the meeting, so we do have a forward plan set out. We are still working with our colleagues with the Institute of Health Equity, so we still have a number of closed sessions coming up as part of our forward plan. You'll note that the first one being in September, which is an update from the employment conference that we had, and we'll start to be trailering in starting well and living well, which Audrey, you'll be leading that part of, so we'll hear more about that in September. But also just wanted to acknowledge that we've got Andrew Dawson in the room today, who is one of our policy officers in the council, and is going to be also taking up some leadership around partnerships and looking at how we conduct our partnerships. And therefore we've got an opportunity just to reflect as a new term, how are we doing as a health and wellbeing board? We've got new members here, and so there's going to be an opportunity for Andrew to come round and have a conversation with people to say what's working well in the health and wellbeing board, what could make it even stronger. I think we've got a strong platform where we've had a bit of a rhythm where ordinarily we have about 3 agenda items a meeting to give us time for discussion. We've deliberately started slower in the new term with just having 1 major agenda item, but just want to highlight this is our board, it's our collective, and it wouldn't work if it's only council dominated papers coming through. So there is that genuine ask to meet the strategy that we've got. We do need all of us to participate, and Andrew's going to help us just to hold the mirror up and just check in where we're at.
Yes, yeah, thank you very much, Jill. Yes, this is not a council-led board. Everybody is an equal. Okay, nobody is more than equal. So please come up with your ideas and everything. And also, as far as, is there anything else you want to say, Graham, on the forward plan? No, okay. Next item is urgent business. Thankfully, I do not have any. And 10th item is next meeting. Next meeting is going to be on 14th of August, 2025, and middle of summer. We will be discussing a few items there. And the 11th one, the following one, is going to be a closed session. Yeah, so we will be meeting with no cameras or anything, and we will be discussing our strategy, basically, tackling inequalities through employment. I think it brings the meeting to a close, but however, this morning I learned something. Our secretary here, Democratic Services staff, Andrea Todd, is celebrating her 25th anniversary in this council. 25 years ago, today, she joined. So congratulations. Okay, that's all. The meeting comes to a close, and have a very nice day and have a very nice weekend. Thank you all for coming. Thank you.